On behalf of the AASLD COVID-19 Working Group, I would like to welcome you to today's webinar. My name is Brendan McGuire, and I will be moderating Clinical Insights, COVID-19 and the Liver, Antibody Testing and Treatment Recommendations. Today's webinar is being recorded and will be available on the AASLD website and in Liver Learning soon. This webinar is designed to be interactive, so we encourage you to ask questions throughout these presentations. To do so, please use the question and answer box located in the top or bottom of your screen to submit questions directly to our presenters and panelists, and we will answer most of them during the question and answer portion of this webinar. In a few days, you'll be invited to a link to evaluate this webinar. We look at these evaluations to assist us in designing future webinars and to update our Clinical Insights document, which will be updated on the AASLD website on Monday, May 4th. Because of your suggestions, we have added a reentry, or how do we gradually return back to normal clinical operations. So your comments are very valuable as we continue to meet the needs of our AASLD family during this pandemic. I would like to welcome our presenters, Dr. Kimberly Brown from Henry Ford Hospital, Dr. Emmanuel Thomas from the University of Miami, and Dr. Laura Kulik from Northwestern University. I would also like to welcome our panelists, Dr. Jamie Chu from Mount Sinai, Dr. Oren Fix from Swedish, Patricia Herron from Columbia, Dr. David Mulligan from Yale, Dr. Daniel Pratt from Mass General, and Dr. Elizabeth Verna from Columbia. The AASLD COVID-19 Working Group is listed here. This has been a great group of physicians to interact with during this pandemic that has rattled our world. This group has made me proud to be a member of AASLD. We do have over 6,700 members. If you are interested in being a member, please go to aasld.org and learn more about membership. This is today's agenda of our webinar. There will be some introductory comments by myself, followed by great presentations from our esteemed panelists. First, Dr. Thomas will discuss antibody tests for the SARS-CoV-2 virus. Second, Dr. Kulik will discuss treatment and NIH guidance. Third, Dr. Brown will present a case. After this, we will have our question and answer session, and then I will finish with closing comments. Before we get to our fabulous speakers, I wanted to review this article published in JAMA on April 22nd, which is a case series of 5,700 sequentially hospitalized patients confirmed positive for the SARS-CoV-2 virus by PCR testing from nasopharyngeal samples between a 35-day period, March 1st to April 4th. Within the 12-hospital Northwell Health System, which serves approximately 11 million people in Long Island, Westchester, and New York City. This study describes the demographics, baseline comorbidities, presenting clinical tests, and outcomes. The data were collected from the electronic health record database. The headline in the mainstream press on April 23rd was a quote taken directly from the abstract that said, "Mortality for those requiring mechanical ventilation was 88.1%. This sentence makes mechanical ventilation seem futile. But this statement was also incorrect, and the authors did correct it a day later. The authors realized they miscalculated the mortality of 88.1% because they took the total number of patients who received mechanical ventilation and died and divided this number of patients who received mechanical ventilation and lived plus those who died. But they did not include the 831 patients still in the hospital and on a ventilator. Calculating mortality using only patients who have had an outcome by the end of the observation period, or April 4th in this case, offers a biased overestimation of mortality. On April 24th, the authors corrected this calculation by changing the infamous sentence to read, for patients requiring mechanical ventilation, 1,151 patients, or 20% of the entire group, 38 or 3.3 were discharged alive, 282 or 24.5 died, and 831 or 72.2 remained in the hospital. Thus, their new denominator includes the number of patients still in the hospital and on a ventilator. While we all know that more of these patients on a ventilator will ultimately die, there is no reason to assume that mechanically ventilated patients will have a mortality close to 90%. This number is probably somewhere between 25 and 88%. However, this article does provide us valuable information regarding demographics of patients with COVID-19 and their outcomes. The patients had a median age of 63 years old, and almost 40% were women. COVID-19 does not care what race you are, nor does it care whether you are rich or poor or have insurance. A list of other comorbidities are listed on this slide. Only 19 patients had cirrhosis, and 11 patients had either chronic hepatitis B or hepatitis C. The most common comorbidities include obesity, diabetes, and hypertension, present in 41.7, 33.8, and 56.6% respectively. Not noted is the median score of the Charlson Comorbidity Index, which estimates the 10-year survival rate for these patients without COVID-19, which was 53%, indicating significant comorbidities in this population. I have listed a few of the presenting laboratory features associated with severe COVID-19 on this slide. The column on the left is the lab test with the reference range in parentheses. The column on the right is the median result with the interquartile range in the square brackets. For the column on the right, with just a number in parentheses, this is the percentage of patients meeting the criteria on the left. Just to highlight a few, the lymphocyte count was low in 60% of patients. 58% of patients had an elevated AST, and 39% of patients had an elevated ALT. Mild abnormalities in AST and ALT are common findings in patients presenting with severe COVID-19. This slide shows the disposition by age intervals of patients who are hospitalized. The age range is shown in the gray column, and the number of patients in the age group is shown in the black column on the far left. For the group 80 years or older, 26% had died, as noted in the red bar. 22% were discharged from the hospital, as noted in the teal bar, and 52% were still in the hospital as of April 4th in the orange bar. For the group between the years of 60 to 79, 9% had died, 31% were discharged alive, and 60% were still in the hospital as of April 4th. As for the group between 40 to 59, there were only 4% who died. As for the group between 20 to 39, there were only 2% who died, and there were no deaths among patients 19 years or younger. The development of acute liver injury, cases that occurred during the hospitalization, as defined as an elevation of AST or ALT greater than 15 times the upper limits of normal, occurred in 1.5%, or 89 patients. For these patients who developed acute liver injury, 60% died, 3% were discharged alive, and 37% were still in the hospital as of April 4th. No additional data is presented or speculated for the cause of acute liver injury. Of note, no patient under the age of 18 developed an acute liver injury. As a hepatologist, we want to know whether our NASH patients who have diabetes and hypertension are more likely to develop acute liver injury when exposed to COVID-19. I cannot answer that specific question, but this data from 56 patients who developed acute liver injury were compared to patients who were discharged or died with or without diabetes or hypertension. comparing non-diabetics to diabetics or non-hypertensives to hypertensive patients, the outcomes were no different. This suggests that patients with underlying NASH are probably not at a higher risk of developing acute liver injury during this infection. However, the authors did find that patients with diabetes were more likely to have mechanical ventilation or need care in the ICU compared to those who were not diabetic. Similar findings were seen for patients with hypertension. What have we learned from this large first case series of hospitalized patients with confirmed COVID-19 in the US? Is that common comorbidities include hypertension, obesity, and diabetes. Very few patients had chronic liver disease or cirrhosis. Acute liver injury occurred in 1.5% of patients and is associated with worse outcomes. There was no pediatric patient who died or had an acute liver injury in this study. Now we will move to our expert panelists. We are very fortunate to have Dr. Emmanuel Thomas, who will share his perspectives on diagnostic testing, which will become so valuable as we try to work our way out of this pandemic. Dr. Thomas, thanks for speaking tonight.
Thank you, Dr. McGuire. By way of introduction, I wanted to point out that there are two general classes of viruses, those that cause persisting chronic infection and those that cause acute infection. Coronaviruses cause acute infection. They can possibly cause mortality, or you can have an immune response that clears the virus. That immune response can provide protection against exposure to the same virus. The degree of protection will depend on the length of time after the initial recovery, since, as with non-persisting viruses, immune responses wane with time. In general, with acute viruses, individuals may become infected again only after a long interval, but usually the severity of the infection is severely limited. The degree of protection will also depend on the degree of antigenic shift between the first infection and the second infection. I wanted to build on this introduction now by speaking about coronaviruses in general. There have been 7 distinct coronaviruses discovered to date that infect humans and cause disease. 4 that cause mild respiratory illness, and 3 that cause severe respiratory illness. SARS-CoV-1 was discovered in 2003 and was the first coronavirus that causes severe respiratory illness. And it used the ACE2 receptor. A year later, another coronavirus was discovered, NL63, that also used the ACE2 receptor, but this one only caused mild respiratory illness, but it spread similarly to other viruses that cause the common cold. Now in 2020, we have SARS-CoV-2, a virus that causes severe respiratory illness and uses the ACE2 receptor, but also spreads in a similar fashion as the common cold. Next slide. In this slide is insight from a large comprehensive screening effort published in 2010 for all 4 common cold coronaviruses by analysis of 11,661 diagnostic respiratory samples collected in the United Kingdom over 3 years between July 2006 and June 2009. And they sampled patients from all age groups. What they found was that individuals usually are exposed and seroconvert to these common cold coronaviruses in childhood. And that's interesting because now many adults for the first time are being exposed to a coronavirus that is SARS-CoV-2 that is unusual when compared to other coronaviruses. What is known is that reinfection with common cold coronaviruses is common, like 229E and OC43 that were discovered in the 50s and 60s. Of the newer coronaviruses that cause mild respiratory illness, NL63 and HKU1 likely also cause repeated infections. And importantly, when they were developing antibody tests in 2003, cross-reactivity between SARS-CoV-1 and 229E and OC43 had been reported, but these can be rectified by additional testing methods, including Western blot that may offer more specificity. From these studies, pan-coronavirus tests that distinguish between exposure to multiple coronaviruses would increase specificity of these antibody tests. Next slide. There are several approaches used to test for SARS-CoV-2, and I just want to briefly go over them. Molecular testing involves detection of nucleic acid, and this will give the tester an idea about whether or not the patient has active infection. Most efforts utilize PCR, polymerase chain reaction, but this requires temperature variation and can take longer in time. Newer non-PCR based methods or isothermal approaches are now being used to facilitate rapid identification of nucleic acids using technologies including TMA, transcription-mediated amplification. In addition to molecular testing, there's also serologic testing, which I will talk about for the rest of the talk. These include viral antigens, which are actual proteins from the virus, and these designate active infection. We're going to focus today on antibody tests that mainly test for antibodies to the virus, including IgM and IgG. And these give you an insight on whether or not an individual has been exposed to a virus. These tests tend to be lower in cost, and they can be amenable to rapid testing. But generation of these tests take longer because they require biologic reagents, including viral proteins as antigens and also capture antibodies. This is different than nucleic acid testing that you can generate PCR primers very quickly that are very sensitive and specific. And we know now that there are antibody tests available from companies including Quest and LabCorp. Next slide. It's important to point out that the SARS coronavirus 2 has multiple proteins that can generate antibody responses. Many of you heard about the spike glycoprotein that's used to bind the ACE2 receptor and enter cells. This protein is also highlighted because many vaccine strategies will be targeting this specific protein. So it's important that in the future, as antibody tests are generated, that antibody tests are using other viral proteins, including the nucleocapsid protein that is produced in a large amount. This will allow distinguish between patients that are vaccinated and those that have been exposed but unvaccinated. Next slide. Here is a diagram of theoretical antibody response profile of someone that's been exposed to SARS-CoV-2. And this is theoretical, and we're still waiting for data to confirm the presence of these responses in humans. When a person is first exposed to SARS-CoV-2, the viral RNA becomes positive. And over time, the patient generates both IgM and IgG antibodies that can control the virus and lead to decrease in viral nucleic acids to undetectable levels. If a second infection is encountered with the same virus, then more robust antibody responses will be produced that should quickly control this second infection. But we don't know if this happens in all patients, and we need more data to really support this model. But this model can really tell us about things that you may have heard of, including herd immunity. Next slide. Now, herd immunity is the idea of population-based development of neutralizing antibody responses that can protect a population overall. Now, we hope that we can generate these neutralizing antibody responses through natural exposure to the virus. But if we're not able to, thankfully, vaccination programs may assist us in generating herd immunity. And what we know is that we need approximately 70% of the population to have functional neutralizing antibody responses to really confer protection through this herd immunity response. Next slide. So some general comments about antibody testing. The antibody response in infected patients remains largely unknown to SARS-CoV-2, and the clinical value of antibody testing have not been fully demonstrated. Seroprevalence data will be important in understanding the scale of the pandemic and future vaccine utility. The presence of these antibodies is really just a correlate of protection. And I want to point out that as many of you know, with the hepatitis C virus, an individual can be antibody positive to hepatitis C, and they can still have chronic infection. In addition, a person that has hep C antibody and that has been cured of this virus can then be reinfected with a different genotype. So protection from antibodies to hepatitis C are not very effective, unfortunately. In addition, I want to point out that to demonstrate that antibodies really are neutralizing, this may require actual in vitro tests involving the SARS-CoV-2 virus performed in BSL-3 labs to actually show that the neutralization antibodies prevent infection. These studies are currently being done, but because of the requirement of BSL-3, there are limited laboratories that can do these studies. Next slide. So the potential utility of these antibody tests are significant. You can detect patients that are PCR negative, especially for patients who present late with a very low viral load below the detection limit of RT-PCR assays, or when lower respiratory tract sampling is not possible by the presence of these antibodies. You can also identify convalescent plasma donors through the presence of antibodies, and this is desperately needed for patients that are currently on vents as a therapeutic strategy. It will also allow us to verify vaccine responses once antibody correlates of protection are indeed identified. And they may support the identification of healthcare workers that can have some protection from future infection by the presence of neutralizing antibodies. Importantly, when we think about chronic illnesses, they can support the identification of patients that may have future exacerbations of comorbid illnesses following an exposure and resolution to SARS-CoV-2. There are also potential drawbacks to these serologic assays, if not well validated. False negative results, if performed early in disease, may appear, especially in patients with mild disease. So you will test the patient too early before they have developed antibody responses. False positives is also a risk, particularly with tests for IgM, due to potential cross-reactivity with common cold coronaviruses that I've already mentioned. Also, if SARS-CoV-2 spike protein is going to be used in vaccines, we will need to test for other viral antigens, including the nucleocapsid, in the future to distinguish between vaccinated and naturally exposed patients. And I also want to point out there's been widespread discussion of immunity passports in the media, possibly given to patients that have antibodies, allowing them to travel. But unfortunately, we don't know if these antibody responses really protect everyone equally. Fortunately, many companies have created assays that are desperately needed to identify antibody patients. But few of these are from companies with an established track record in the virology testing space. And I encourage you to go to the website covidtestingproject.org to see data from multiple tests from currently available antibody testing strategies. From their initial studies, very few really perform highly with respect to sensitivity and specificity. Next slide. Here are two antibody testing platforms that are currently being used. The first one that I'm showing you here is a lateral flow assay or immunochromatographic strip test. This is commonly used from the company OraSure that has tests available for both HIV and Hep C. These tests are performed one at a time as a point of care test, and they can be done in around 20 minutes. So they're a great value to the community. But they tend to be higher in cost, and Hep C and HIV tests can be around $20 using this methodology although we hope prices will decrease with the SARS-CoV-2 tests that are available. And I've heard testing being available around $10 for these rapid tests. There's another platform that uses the ELISA technology that's more amenable to high throughput screening. And this ELISA platform can be even lower in cost, approximately $5 per test. And both of these tests just require serum or plasma. So there are great technologies available to be used for antibody testing. And these ELISA tests can be automated and performed even in a more high throughput fashion as present in many CLIA certified labs. And those tests can perform hundreds of testing for antibodies per day at a very low cost. Next slide. So I wanted to just show you some more innovative research that was recently presented as a bioRxiv preprint. In this publication, they used pseudotyped lentiviruses with the SARS-CoV-2 spike protein. Now, this system only requires a BSL-2 safety level, so it's something that many laboratories can perform. In the study, they detected neutralizing antibodies from the sera of COVID-19 convalescent patients, which is exciting. They used linear peptides and functional assays, and they identified 2 regions of the spike glycoprotein that were highly recognized by neutralizing antibodies in patient sera. One target was highly specific for SARS-CoV-2, while another target is a possible pan-coronavirus target. Of the 25 patients sampled, they found strong neutralizing activity in 6 patients. So we don't know if all individuals will develop neutralizing antibodies that are functionally stopping virus infection, and more research is needed in this area. Next slide. I wanted to finish by talking about antibody testing in immunocompromised individuals. What we know is that antibody responses is impaired in older individuals, persons living with HIV, and other immunocompromised individuals. Both B and T cell compartments are adversely affected in these individuals. And testing may be needed a second time, several weeks after an initial test, if it is negative, to confirm that the patient is indeed antibody negative. Also, multiple testing approaches will most probably be needed to appropriately characterize immune responses in these individuals. Next slide. So to conclude, I'd just like to point out that antibody responses in infected patients remains largely uncharacterized for breadth and potency, and research is being done to clarify this issue. Differences in the generation of neutralizing antibodies against SARS-CoV-2 between individuals have been observed, and these differences are likely important. False positives and negatives remain a concern. Importantly, serology tests are under development from established companies, and these tests will likely have higher sensitivity and specificity than current tests that may be available now. Also, appropriate neutralization assays performed with SARS-CoV-2, the actual virus, are underway, but necessitate BSL-3 facilities. And we hope that neutralizing antibodies that have been identified in BSL-2 level viruses can subsequently be confirmed using SARS-CoV-2 in the BSL-3 environment. Thank you, and I will end here.
Dr. Thomas, thank you very much for that excellent overview. You had some good questions, and we'll come back to the question and answer session to get to these. To beat COVID-19, we need to identify patients with antibody testing, as we just heard. We will also need to isolate and treat individuals to get rid of this awful virus. Dr. Laura Kulik will give us an update on clinical trials. Thank you, Dr. Kulik, and we look forward to your presentation.
Thank you, Dr. McGuire. In early April, the FDA announced emergency use authorization of hydroxychloroquine as a potential therapy for hospitalized patients with COVID-19 in whom a clinical trial was not available. Today, I will review the results of 2 clinical trials using chloroquine and hydroxychloroquine. Next slide. The first trial was conducted in a single center in Brazil. Patients were randomized to high-dose chloroquine versus low-dose chloroquine. When the trial was first designed, the primary outcome was a decrease in mortality of at least 50% in the high-dose group by day 28. However, an unplanned interim analysis by the DSMB due to safety concerns led to premature closure of the study. At the time of closure, there were 81 patients who had been randomized, of whom the majority had confirmed COVID-19 at the time of randomization. This paper reports the secondary outcome of mortality at day 13. It's important to note that all patients were treated per protocol at the hospital with ceftriaxone and azithromycin for possible pneumonia, and approximately 90% were also empirically treated for influenza. The median age of the entire cohort was 15 years old, and younger at 47.7 years, compared to the high dose group at 54.7 years. Also, there were higher rates of known pre-existing heart disease in the patients who composed the high dose group. And additionally, only 2 of 81 patients had known liver disease in this cohort. Next slide. The overall lethality at day 13 was 27.2. The gray bars represent the fatality of historical controls of similar patients with COVID-19 who were not on chloroquine. The yellow line represents the high dose group, which separates early on from the low dose group in the blue line in both all patients as well as those who were in the ICU. In the bottom, I've highlighted in the red box that there were numerically higher cardiac events such as increased CKMB, QT prolongation greater than 500 milliseconds, and ventricular tachycardia in the patients who were in the high dose group. Next slide. The high dose group was associated with a significant higher mortality rate. However, after adjusting for age, the high dose chloroquine group was no longer significantly associated with mortality. It should be noted that the 5 patients in the high dose group who had pre-existing cardiac disease had a significantly impressive mortality at 60%. A total of 12 patients in the entire cohort had prolonged QT or ventricular tachycardia. By day 4, only 22% of patients had undetectable RNA by nasopharyngeal swab, and there was no significant difference in this detection between the high and the low dose group. The authors concluded that this study suggests that high doses of chloroquine should not be recommended in patients who are critically ill with COVID-19 due to concerns for safety, and especially when patients are taking concomitant medications that can prolong QT intervals. However, these findings could not be extrapolated to patients with non-severe COVID-19. Next slide. The limitations of this study include that this was a single center study. There was no placebo arm for comparison. This was a small sample size. There was no exclusion of patients based on an EKG prior to administration of chloroquine, and there was an inability to perform per protocol analysis. Next slide. An ongoing randomized controlled trial also in Brazil is comparing low-dose chloroquine versus placebo in adult patients with COVID-19 who have comorbidities without the presence of SARS. The primary endpoint of this trial will be the development of SARS within 7 days of randomization, and patients are excluded if they are on chronic medications that are known to prolong the QT interval. Next slide. The second study is from the VA. It is a retrospective study that consisted of 368 patients who were all male, predominantly African American, with a median age of greater than 65 with confirmed COVID-19 infection. 3 groups were analyzed: monotherapy with hydroxychloroquine, combination therapy of hydroxychloroquine plus azithromycin, and group 3 was no hydroxychloroquine. 3 study outcomes were examined: discharge or death, if ventilation was required, and outcome in ventilated patients. Propensity scoring adjustment was performed at baseline for demographics, which were similar in the 3 groups, and markers of disease severity using vital signs and laboratory parameters were more pronounced in the group receiving hydroxychloroquine. Next slide. Mortality was significantly higher in those treated with hydroxychloroquine versus no hydroxychloroquine. Next slide. However, the need for ventilation was not impacted by the receipt of hydroxychloroquine. Next slide. As stated earlier, propensity scoring was based on baseline characteristics, and models took into account the competing risk of death with the risk of discharge or risk of death prior to ventilation. Mortality after adjustment was significantly higher in the monotherapy hydroxychloroquine group compared to no hydroxychloroquine. However, the combination group did not significantly show an increase in mortality compared to no hydroxychloroquine. Next slide. The limitations of this trial this was a retrospective analysis. The population was all male with a median age exceeding 65 years old. There was no data on the dose of medications that were received. There was missing data for many of the variables that were analyzed, and there was no report of side effects. The authors concluded that the use of hydroxychloroquine with or without azithromycin did not impact the need for mechanical ventilation, and there was an increase in overall mortality in patients who were treated with hydroxychloroquine, and that there are further additional trials that will be needed before this can be recommended as a treatment. Next slide. Shortly after the release of this last study, the FDA issued a warning regarding the use of hydroxychloroquine in patients with COVID-19, specifically citing the risk of QT prolongation and the combination of other agents that can lead to prolonged QT interval. Next slide. The upper panel are recommendations from our cardiology colleagues to avoid hydroxychloroquine in patients with a baseline QT that exceeds 500 milliseconds, to avoid concomitant drugs known to prolong QT interval, to supplement potassium greater than 4, and to follow the QT as early as 2 to 4 hours after the initiation of hydroxychloroquine. On the bottom, I just wanted to point out that cirrhotics often have a prolonged QT interval as a result of cirrhotic cardiomyopathy, and further caution may be warranted in these patients. Next slide. There are some other potential therapies that have recently been reported in the news that I will briefly review. Next slide. It was noted in China that patients taking H2 blockers were having an overall improved survival compared to patients who were taking PPIs. In early April, hospitals in New York started a randomized controlled trial in critically ill COVID-19 patients with high-dose IV famotidine plus hydroxychloroquine versus hydroxychloroquine alone. The dose of famotidine is 9 times higher than the oral dose that is used in the treatment of reflux. The goal enrollment is close to 12,000 patients, and the proposed possible mechanism of action is the blocking of a crucial enzyme for viral replication. Patients with renal dysfunction are not eligible for this study, as it is required dose adjustment for patients with GFRs less than 60. Next slide. It should also be pointed out that very recently the FDA called for removal of a different H2 blocker, ranitidine, due to concern for containing a cancer-causing product, NMDA. Now this, combined with the slide that I just showed you, may cause confusion in the general population. Next slide. Also bringing it back to our cirrhotic patients, it's important to be aware that acid blocking mechanisms have been shown in multiple trials, including this meta-analysis, to increase the risk of infections, specifically SBP. And while this risk is higher in patients who are taking PPIs, it is also significantly increased in patients who are taking H2 blockers. Next slide. The most recent development is a press release from yesterday that showed the results of the adapted COVID-19 treatment trial, which enrolled over 1,000 patients randomized to remdesivir versus placebo. The primary endpoint was median time to recovery or discharge, which was significantly less at 11 days in the remdesivir arm compared to 15 days in the placebo group. This was a 31% increase in the time of recovery in the patients who were treated with remdesivir. Also, there was a trend for improved survival with remdesivir at 8% mortality versus 11.6% mortality in the placebo arm. Next slide. My last slide is a summary of the NIH expert opinion regarding the treatment of COVID-19. This is a document that will be updated based on scientific results. There are two classes of therapy that are included, antivirals as well as immunotherapy. There is insufficient evidence to recommend for or against the use of hydroxychloroquine. A similar recommendation has been made for remdesivir. However, given the recent results that were posted yesterday, it is expected that this recommendation will likely change. The FDA recommends against the use of hydroxychloroquine in combination with azithromycin or HIV protease inhibitors outside of a clinical trial. In terms of immunotherapy, there's insufficient evidence to recommend for or against convalescent plasma or interleukin-6 or interleukin-1 inhibitors. And they do recommend against the use of all interferons and Janus kinase inhibitors outside the use, outside a clinical trial. Thank you.
Dr. Kulik, thank you very, very much for updating us on this ever-changing world of treatment. Unfortunately, with limited treatment today, the pandemic continues to make its way across the United States as it's hitting some areas really hard. One of those areas is Detroit, Michigan. And we are fortunate to have Dr. Kim Brown present a case. Dr. Brown, the microphone is yours.
Thank you, Dr. McGuire. I thought what I'd try to do is take some of the information that we've been learning about this virus and apply it to a case with questions that I think were posed when we see patients as consultants. So this is a case of a 64-year-old African-American woman with multiple comorbidities, including coronary artery disease, hyperlipidemia, hypertension, and diabetes. She was diagnosed with autoimmune hepatitis in 2018, and the biopsy at that time showed bridging septa and a few nodules. She was treated with prednisone, which was eventually tapered off, and then she was maintained on azathioprine 100 milligrams daily and had continued normal liver tests. Up until January of this year, when routine surveillance labs showed an elevation of her AST to 110, ALT had risen to 86, she was placed back on prednisone and continued on azathioprine. Next slide. On 3/16, her ALT had returned to normal, and the prednisone was started to taper and decreased to 30 milligrams daily. Azathioprine was continued at 100 milligrams daily, and 10 days later, she presented to the emergency room with nausea, diarrhea, cough, shortness of breath, weakness, wheezing, headache, anorexia, myalgias, and blurred vision for the past 4 days, and her husband brought her in that day because of an episode of syncope. In the emergency room, her oxygen saturation was 88%. This did improve to 96% on 2 liters. She had a temperature of 99.8. Her chest x-ray showed a right lower lobe infiltrate, and she was tested for COVID and was found to be positive. Her medications as an outpatient had included chlorthalidone, losartan, aspirin, atorvastatin, carvedilol, and dulaglutide. Her chlorthalidone and carvedilol were held. Initially, she had hypotension on presentation to the ER, and she was started on ceftriaxone and doxycycline for possible associated bacterial pneumonia, as well as hydroxychloroquine, 400 milligrams twice a day for 2 doses, and then 200 milligrams twice a day to complete a 5-day course. Her oral prednisone was held, and she was given pulse steroids, methylprednisolone, 40 milligrams IV every 12 hours at that time. So her laboratories on admission showed normal liver enzymes. Her AST was 29, ALT was 22, bilirubin was 0.6, ferritin was elevated at 754, CRP was 3.3, CPK was 103, platelet count was intact at 198, and her absolute lymphocyte count was significantly depressed at 0.7. On 3/29, she became hypertensive in the hospital. Her losartan was restarted, and on 3/21, she desaturated to 82%, required a non-rebreather, was moved to the ICU, and the following day was intubated. Hepatology was consulted at that time, and by the time hepatology saw her, she had completed her hydroxychloroquine and pulse steroids. She was receiving 30 milligrams orally of prednisone and was continued on azathioprine 100 milligrams daily. Hepatology recommended discontinuation of her azathioprine and to continue prednisone 30 milligrams daily alone. The patient was eventually extubated on 4/7. She did remain hospitalized as she continued to require oxygen. Her laboratories on the 15th showed again normal liver enzymes, 25 and 26. Her bilirubin was 0.4. Her inflammatory markers had significantly improved. CRP was 0.1, ferritin 239, CPK 84, and her absolute lymphocyte count had risen to 3.4. Her COVID testing on 4/11 was negative, but repeat testing on both 4/16 and 4/17 were positive. She was eventually discharged home on 4/20 with home oxygen and 40 milligrams of prednisone daily with follow-up. Her liver tests at the time of discharge continued to remain normal. So I think there's several questions that could be posed to us as consultants when we see a case such as this. And many of us have been presented with questions, especially around our patients with chronic liver disease or transplant who are receiving baseline immunosuppression and whether they are at increased risk of infection or severity of infection if it occurs. And there are really no good data to answer this question clearly because many of these patients, as was pointed out in prior slides, have significant additional comorbidities that likely impact their risk. There's no convincing data to suggest that patients who are immunosuppressed are at higher risk of contracting the virus, but there is concern that their course could be adversely affected by immunosuppression. In transplant patients, as an example, on immunosuppression, those individuals in prior outbreaks of SARS or MERS did not appear to be at higher risk of mortality as compared to other patients. And in this case, our patient was really on steroids to use as a control of her underlying disease process. And given the lack of evidence, I think that suggests immunosuppression should either be stopped or held, I think it was prudent to continue steroids at a reasonable dose to control her disease. The other question is regarding high-dose steroids. So this is used as a protocol in our moderate to severe patients in our hospital. And this is really based on some data from China, which was observational alone, suggesting that there may be a role with high-dose steroids. The CDC actually recommends against this unless indicated for other reasons. But because this was a protocol in our hospital, the question that we would have been posed was there a detrimental effect in the setting of chronic liver disease? In our patient who was already on steroids, I think the answer to that would be no. And I think this patient would likely have been, we would have agreed to put them on high-dose steroids if indicated for another reason. The second question is around ACE inhibitors or ARBs. There was some early data that hypothesized that angiotensin-converting enzyme inhibitors or angiotensin receptor blockers could increase the risk of SARS-CoV-2 infection or severity of illness. And ACE inhibitors and ARBs increase the expression of angiotensin-converting enzyme 2, and we recognize that the virus uses this receptor to enter into the host cell. But to date, there really are no data that suggest a link between either the use of ACE inhibitors or ARBs with worse outcomes from the infection. And so when this patient who had their losartan held due to hypotension was restarting, the question I think early on in this infection was whether that was prudent or whether we should choose another antihypertensive. Several societies have actually come out with recommendations, including the American Heart Association, Heart Failure Society, the American College of Cardiology, And they have all suggested uniformly that you should continue these drugs for patients who are already receiving them for cardiac indications. And this was supported by the AASLD Clinical Insight Guidance document as well. The next question is, what should our approach have been to managing the azathioprine and the prednisone during this event? So we can look at recommendations from several societies, including the AGA, recommending patients with IBD have a reduction to lower dose steroids, but not a cessation, but a temporary cessation of thiopurines and methotrexate. A guidance from our society as well suggests reducing azathioprine or MMF in the setting of moderate to severe symptoms. And this is similar to what we see, I think, in practice in transplant recipients, where steroids or CNIs may be continued or reduced, but certainly not held. But we do tend to hold MMF in the setting of infection. Given, I think, the clinical stability of the liver disease in this patient prior to admission and her overall presentation, I think it was probably prudent to hold azathioprine during this time and continue her on maintenance steroids alone. The next question goes back to Dr. Kulik's presentation regarding hydroxychloroquine. So I don't think any of us are going to be asked how to treat a COVID patient, but we will be asked about the safety of the medications that are either being used per protocol or off protocol. Hydroxychloroquine has really not been associated with significant liver function abnormalities, and it is an extremely rare cause of clinically apparent acute liver injury. It is important to remember that these drugs can concentrate in the liver and can be associated with abnormal liver function and acute liver failure with prolonged use. But in general, these protocols for use in COVID-19 infection have been limited to 5 days of treatment, making this risk, I think, unlikely. And then finally, Dr. Kulik covered some additional medications, including the anti-IL-6 and remdesivir. And it's an important question, I think, that you can be faced with when doing a consult. Both of these medications have been used in clinical trials and either are being used in the case of remdesivir in compassionate use capacity or off-label in some cases for moderate to severe presentation, depending on the institution that you're at. And I think in advising the potential safety of these drugs in patients with chronic liver disease, what I try to do is balance the known risk without treatment against the potential risk I think that the medication could pose based on current information. So when we look at the risk benefit, we see from many studies that the risk of overall mortality in hospitalized patients probably sits around 8 to 15%. Those are all comers, and clearly higher in patients who require ventilation. And we know that with these compounds, grade 1 to 2 elevations have been seen, ranging perhaps up to 40%, with very rare cases of severe elevations or acute liver failure. The recommendations for all of these drugs is to avoid them in patients with ALTs greater than or equal to 5 times the upper limit of normal. And I would refer you back to the AASLD guidance document, which outlines the various medications and side effects. But I think for this patient, had I been posed that question, given the high morbidity in this population and the relatively limited evidence of severe toxicity with these drugs, I would suggest that the potential benefit outweighs the risks in our patients with chronic liver disease. Thank you.
Thank you very much, Dr. Brown. Really appreciate that. Appreciate you providing your insights on this particular case and her management. I think all of our presenters actually did a great job shedding light on the subject and giving us hope that we can beat COVID-19. Now we'd like to open it up to our question and answer session. Let me start here. First question we have. Since COVID-19 binds to the ACE2 receptor, which is located on biliary epithelial cells, are patients with cholestatic liver disease at an increased risk of worsening liver disease? I'll forward this question. How about Daniel Pratt, since you're an expert in autoimmune and cholestatic liver disease? Daniel? We may come back to you, Daniel, just because I think you're on mute. Sorry about that.
Oh, is that better? Is that better, Brendan?
Go for it. Great. Thank you very much.
Thank you. Sorry about that.
Oh, you're
No,
good.
the short answer here is I don't think so, but this is sort of an interesting question. And when you think about it, in our PBC and PSC patients, we haven't yet seen any direct data in that very rare group of patients. But we do have a couple of important pieces of indirect data that support the fact that I don't think these patients will be at increased risk. And the first is that we know in the COVID-19 patients who have abnormal LFTs, the pattern of those LFTs is not typically cholestatic, which is what we might expect if an immune-mediated attack on infected cholangiocytes was an important component of the liver injury in this disease. And then the second bit of data is that we have very limited hepatic histology in COVID-19, and none of those reports describe a lymphocytic infiltrate of the portal tract, which again supports the fact that there is not an immune-mediated response against these infected cholangiocytes. What we have seen in histology is that we do see lymphocytes in the hepatic sinusoids, which actually makes great sense when we remember that ACE2 is strongly expressed on endothelial cells. So the bottom line is we still don't know if the expression of ACE2 on cholangiocytes is contributing to the liver injury we see in COVID-19, but I'm pretty confident our PBC and PSC patients will not be at greater risk of injury.
Very good. Thank you very much. We'll move now to this question. How about Dr. Jamie Chu? I have a question for you based on your experience from Mount Sinai. In cases of acute liver injury, how elevated does total bilirubin, alkaline phosphatase, and GGT become? Jamie?
Yeah, we would also agree with Daniel in that our pediatric experience with COVID-19 at Mount Sinai is similar to that in adults, in that the majority of our affected pediatric patients have a mild hepatitis. That being said, we're seeing transaminases greater than 10 to 20 times the upper limit of normal in some of our oncology patients with COVID. But in all of the patients, the hepatitis usually self-resolves as they clear the virus. Even in the midst of the hepatitis, even in our patients with underlying liver disease, the bilirubin and GGT levels have largely remained normal. We know that children seem to be more resilient to this disease. And to that effect, we are actively working to profile the acute immune response to the COVID infection in children, and to use this information in the future to potentially find ways to recapitulate these responses, these pediatric responses in adults.
Jamie, I agree with your comments. Thank you very much. The next is a two-part question, and I'll send this to David Mulligan, given his experience as chair of the Liver and Transplant Committee at UNOS. The question is, should we be transplanting patients with COVID-19? The next part of it is, how long should we wait for a COVID-19 positive patient before it is safe to transplant? David?
Okay, so that's a great question, and I think at this point in time, it's felt by all around the world that transplantation for patients who are positive with COVID-19 is a bad idea. The mortality is high. Most of the patients who were transplanted with unknown status at the time of transplant, but turned out to be COVID positive, ended up with bad outcomes and usually succumbing to a pulmonary related mortality. So they didn't do well. So we screen every transplant recipient, regardless of the organ, for COVID to make sure that they're COVID negative before a transplant. With regard to when it's safe to transplant, it's a very good question. Right now, I think the current practice that we're trying to look at in the American Society of Transplant Surgeons is to try to have a minimum of 2 PCR tests negative post resolution of symptoms, and probably 21 days after the symptoms have gone away would be the guideline that we'd use. I think you have to balance the severity of the liver disease, the MELD score, and that against the risk of recurrence of the COVID infection for every patient. So if you can wait, waiting longer is better, but I'd say 21 days would be what we would hope at the end of the symptom resolution, and 2 negative tests.
Very good. David, thank you very much for your insights.
Sure.
This question is regarding how do we ramp up our outpatient clinic operations, including how should we handle clinic seeing COVID positive patients. I'd like to direct this to Patricia Herron to address this question, given her experience of managing all the outpatient transplant clinical operations for all organs at Columbia University. And then during this pandemic, she transitioned to the inpatient floors, caring for COVID-19 patients. Patricia?
Yeah, so when planning to reopen on-site operations to start seeing patients back in the office again, you need to consider a few things. We're considering the shelter within order. When does that expire in your state? That also, because that has a huge impact on the availability of transportation for your staff and your patients. Also, the access and stock of adequate PPE to meet your visit volume. How often are people going to have to change their gowns? Things like that. Do you have enough to support your weekly operations? At the medical center campus, we are limiting our office hours. We have divided our multi-organ outpatient clinic into separate days for each organ type. This gives each organ the availability of many rooms so they can see their patients on shorter days of the week. We've divided our staff, clinic staff and back office staff, our clinical staff, our wait list coordinators, et cetera, into teams. And some days a team A will work remotely and sometimes they'll be in the office, because you have to remember you need to social distance your office as well. And many of us, I know Columbia is not alone, where we have many people in one office and there's no degree of social distancing. So this is important to meet, especially if you're planning on to ramping up over in the month of May. So we're taking this approach. We are also increasing the length of time each patient is scheduled by a minimum of 15 minutes. This, we hope to decrease wait time with the goal of 0. So if a patient shows up, they can be put in a room right away. We're also instituting no companions unless it's physically necessary. We are changing the customizing our wait room, decreasing the number of chairs and increasing the space between them. We're also instituting, patients are being instructed to go to one entrance. The number of available entrances at the medical center has decreased, but all patients will be told to use this one entrance. They will be met in the lobby at a transplant welcome table. They will be part of this team at the welcome table will be a nurse or a medical assistant who will do a thermal temperature scan. If a patient has an elevated temperature, they'll be escorted to a close by fever clinic for evaluation and lab work, and their visit will be converted to a video visit. This will hopefully decrease the amount of exposure on non-COVID positive days. We've also instituted COVID days for just COVID patients. And all organs will use this day to see their COVID positive patients. Patients can get labs done, can get infusions seen by providers. We're starting this with Fridays, and that is so that we can have enough time for terminal cleaning. Those patients will also be met and escorted up on a specific elevator that will go from the first floor to our clinic floor. And that elevator will also need to be terminally cleaned. So we're choosing Fridays to allow the maintenance staff to be able to do that. So there's a lot of things to consider. Certainly things will be stricter early on, but it's not only what you do in your clinic, it's what you do in your offices. So there will be different mandates for allowing essential and non-essential people back, and you have to look at your physical space where all these people do their day-to-day work.
Wow, that's a lot of things to consider. Thank you for that input, really appreciate it. So that's the East Coast perspective. I'm curious how outpatient clinics are handled on the West Coast. Dr. Orrin Fix from Seattle, how will you ramp up outpatient clinical operations and deal with COVID positive patients?
Well, I agree with your reaction to Patricia's response. That is a very thorough response, and I'm quite impressed that even in New York City, where you're barely past the peak, you're already starting to think about how you're going to return to normal in a very thoughtful way. I'm embarrassed to say that I don't think we're quite there yet in Seattle, despite the fact that we fortunately avoided the surge that New York City saw. But I think I don't want to repeat what you already said. I think everything you said is absolutely spot on. I think the point here is a couple of things that I'd like to add. One is that we all do need to start thinking about how we're going to get back to normal, just like the economy and restaurants and all kinds of other businesses are thinking about safe ways to do this. We need to do that in the healthcare business as well. And even in places like New York, where you're still almost overwhelmed with the amount of COVID patients, it is time to start thinking about how we're going to strategically, thoughtfully, carefully go back to maybe not normal, but a closer, point where we're back to where we used to be before the pandemic. I also think it's important to be aware that we can't just flip a switch and open up our clinics to all patients. We need to continue to be very careful about triage. I think we still need to consider who really does need to be seen in person, who can be seen via video, and who potentially safely could be postponed and rescheduled to a later time. I also wanted to mention that I think liver transplant evaluations in particular are going to be, they will continue to be very hard to do by video. The interactions between the family and the caregiver is really important. Physical exam is important. Generally, most programs are getting labs and imaging during their evaluation as well. So we need to probably think about bringing those patients back into the clinic sooner than other patients. I want to point out one thing that I know UCSF is doing that's quite interesting. They're doing sort of a hybrid clinic of video as well as in person. So even though the patient is actually in the clinic, most of the interactions are via video with the provider in another room, and the patient is there so that the provider can come in quickly and do an exam and then leave, and also to allow the patient to get their laboratory and imaging that needs to be done and sign consents, things like that. So that's an interesting, I think, innovative way to go about this to protect the patients and the healthcare staff. So I think it was kind of a roundabout way to answer your question, Brendan, but I think I don't see any reason why Seattle is going to do things any differently than the way Patricia described it. And I think every program needs to think about very strategic ways to do this so that we're doing it thoughtfully and ensuring the safety of our patients and our healthcare providers.
Thank you very much, Oren. I appreciate that. The next question here, given the numbers from Italy that up to 20% of healthcare workers have been identified with COVID-19, what testing is being done to the healthcare workers in the United States? I'll select Betsy Verna for this one to address this question, given her experience at Columbia University. Betsy?
Yeah, great. Thank you. I think this is a question on everyone's mind in our community. I would say not just for healthcare workers, but also I think patients are very interested in being tested. And I know at Columbia, we've started to test our healthcare workers sort of on a voluntary basis. We're using an in-house assay that that's now been validated and I think is very, very specific and pretty sensitive, especially around the 3-week mark. So there's a big effort to try to get staff and employees tested at Columbia. But I just want to, also say, echo the caveats that have been described earlier in this webinar that, I think it's very important for us to understand what proportion of the staff has been exposed. But clearly, we really don't know how to use this information in order to guide any subsequent staffing or any additional events to occur in the future. So I think we're, as a community, still largely in the information gathering phase. And this is something I also tell to patients who are now flooding our office with calls to try to get clinical antibody testing done, many of whom have mentioned things that were mentioned earlier, including using this as a way to be, quote unquote, cleared to fly or to go back to participate in normal activities. And I think it's really important to make sure that both patients and clinical staff know that we really don't know to what extent any of these antibodies are protective. But it is very important for us to get all this testing done for us to start to answer those questions.
Thank you very much, Betsy. Appreciate that. I'd like to close with two questions, one for Dr. Thomas and then one for Dr. Kulik. And I guess it's a question for Dr. Thomas. Regarding the SARS-CoV-2 vaccine, can it induce a hyperimmune reaction as was seen in the dengue or animal studies of SARS?
Thank you for that question. I think that there's two different phenomena that we're talking about here. Number one, a phenomena called antibody-dependent enhancement that's seen in patients that have had dengue infection, and then vaccine-dependent enhancement that was seen actually with vaccines that were used against SARS-CoV-1. Now, it's assumed that those vaccine-dependent enhancement responses where subsequent SARS-CoV-1 infection was worse is due to antibody. And specifically, they implicated the spike protein being used as an antigen to actually contribute. And there's been some publications to illuminate the mechanism as to how this happens. I think the vaccines need to be developed and they need to be done carefully. And safety is a paramount concern to make sure that patients that are getting vaccinated are not then getting infected and having worse outcomes. So unfortunately, this is a complication that all of the vaccine makers for SARS-CoV-2 are going to have to deal with. Thank you.
Thank you very much. Laura, last question to you. If you had COVID-19, would you take remdesivir?
Yes, I would.
I would agree with that too. Yeah. Thank you very, very much. Any other comments from our panel? Anybody? We have really exceeded our limit. Sorry about that. But I wanted to make sure we at least answered most of the questions. I applaud our panelists for their input. And this will be our final slide. That was our final slide. This will be our final slide. Was our final slide. Okay. Please continue to follow us on the AASLD website. Again, on Monday, May 4th, we update our clinical insights document. Please join and interact with us on the COVID-19 care community Engage. We're also now accepting and fast-tracking reviews of COVID-19 original articles and case reports submitted to our journal. On behalf of Dr. Becerra, President of AASLD, as well as our entire organization, we will be with you throughout this pandemic and will continue to provide education, tools, and practical resources to help you in the management of patients with liver disease. We hope you found this webinar helpful, and we look forward to interacting with you again on future webinars. Please be safe and have a good night. Thank you very much, everybody.